Welcome and good afternoon to everyone. My name is Mike Potter, and I'm a professor of family and community medicine at the University of California in San Francisco. I'm joined in moderating this session by Dory Lane, the Distinguished Service Professor at Stony Brook University School of Medicine and representative for the American College of Preventive Medicine for the National Colorectal Cancer Roundtable. Together, we serve as co-chairs of the NCCRT Professional Education and Practice Implementation Task Group. We are so pleased to be able to help moderate this webinar this afternoon. Thank you all for joining. We've had a lot of interest in this topic, and we really appreciate your engaging with us. The purpose of this webinar is to provide hospitals and health systems with advice on the design and delivery of a variety of effective colorectal cancer screening interventions using lessons learned from our new resource, the Colorectal Cancer Screening Best Practices Handbook for Hospitals and Health Systems. With their expertise in improving health and in serving as leaders in their communities, hospitals and health systems are uniquely positioned to play a pivotal role in increasing colorectal cancer screening for those they serve. In fact, hospitals and health systems make up the largest number of partnering organizations that have signed the pledge to get to 80% screening for colorectal cancer nationally. And most of the lessons learned and that are featured in the guide came from interviews with hospitals and health systems leaders who have signed the pledge and who have been working to turn that commitment into local action. The potential to work with hospitals to leverage their unique position in the community to save lives from this disease is huge, and we are grateful for this incredible commitment and enthusiasm. Moreover, those who work in hospitals and health systems see the results of missed opportunities every day, such as when someone who has never been screened faces a cancer diagnosis. But they also see the stories of success, such as when a cancer is detected early or even prevented altogether through screening. Today's webinar aims to review the critical steps that hospitals and health systems can take in advancing colorectal cancer screening efforts and familiarize participants with our new handbook. Additionally, we will hear from two health systems leaders about their experiences implementing colorectal cancer screening interventions and who both represent systems featured in this handbook. We will also save some time for questions at the end. Now, let me turn things over to my colleague, Dory Lane, who will tell you all about how to find the new handbook.
Thank you, Mike. On this slide, you'll see a screenshot of the NCCRT Resource Center, which is where you'll be able to find the new handbook for hospitals and health systems that is now newly available, hot off the presses, so to speak. Hopefully, everyone is familiar with the updated nccrt.org website. You can navigate to the Resource Center from any NCCRT page by finding it listed in the main navigation menu at the top of our site. As you can see, it's circled in the upper right-hand corner. Once in the Resource Center, you can find a number of wonderful evidence-based tools and resources that can help you increase colorectal cancer screening in a range of practice settings and with varied populations. Filters are available to search by practice setting, target audience, intervention type, and more, which makes it easy to find tools tailored to working in specific populations. You can also use the search bar if you know the name of a particular resource or a topic that you'd like to learn more about. Finally, users can also submit their own resources to share. It's truly a one-stop shop to assist you in your work, and I strongly encourage you to check it out. With that said, I'm pleased to introduce the presenters for today's webinar, who are pictured on this slide so you can see their friendly, welcoming faces to colorectal cancer screening. Today we'll hear from Mary Dorshank, Director of the NCCRT, who will review the critical steps hospitals and health systems can take to increase CRC screening. And next we'll hear from two wonderful leaders whose health systems are featured in the guide and who will describe their real-life experience putting this work into action on the ground. We'll hear from Dr. Andrew Albert, Medical Director of Digestive Health Centers at Advocate Illinois Masonic Medical Center, and Dr. Amanda Bolivar, Medical Director at Deaconess Clinic. Finally, I'd like to share a few technical items before we get started. First, we're recording today's webinar. The replay and speaker slides will be shared with all of you within a few days. Please feel free to share it with your colleagues that were not able to join us today. Also, because of the large number of participants, all participants are muted on today's webinar, including you. But we still want to make sure you get what you need out of the webinar, so we encourage you to ask questions by submitting them through the webinar Q&A function. Just type them in. We will have time for questions after the presentations, and we'll answer as many as we can. And we'll also be emailing around responses to any questions we don't have time to get to. You can also email us specific questions that may occur to you afterward. And finally, we are always eager to improve our webinars, so we need your help in evaluating the webinar. You'll be receiving an email with a survey link. Please help us out with this by taking a few minutes to provide feedback. We take your advice very seriously and are always trying to improve these tools to make them maximally useful to you. Now that I've covered the ground rules, let's get started. I'm pleased to introduce you to our first presenter, the amazing Director of the NCCRT, Mary Jorshank. So let me move you along to Mary.
Thank you for that warm introduction, Dory. And before we get started, I just really want to thank all the folks who are on the advisory group that helped develop this new handbook. It was really quite an intensive project with a lot of phone calls and a lot of requests for reviewing different outlines and drafts. So sincerest appreciation. My expertise is in colorectal cancer screening, not hospitals and health systems, and so I really learned a lot from the folks on the phone. So thanks very much. The folks on the advisory group. And before we get started, I just want to take a moment to explain who the NCCRT is. We are a coalition co-founded, co-supported by the American Cancer Society and CDC. We are an organization of a whole bunch of different groups, medical professional societies, survivor groups, federal agencies, state health departments, academic institutions, all working together with a laser-like intensity to increase colorectal cancer screening rates. We often do that by producing different tools and resources, as Dory mentioned, that are available on nccrt.org. These resources often take a lot of the best of what's going on in the field and repackaging it and getting it out to all of you so that we can reduce duplication of effort and don't have to recreate the wheel. A lot of our resources also aim towards the goal of increasing colorectal cancer screening rates to 80%. And there are 4 different aspects of our strategic plan to get to an 80% screening rate. These include moving consumers to action, systems change using providers, hospitals, payers, and employers to support screening, policy, so how do we remove access barriers and address policy issues that can increase screening, and then process, how do we evaluate our efforts and hold ourselves accountable. And from the very beginning of our strategic planning process, we recognize the important role that hospitals could take in increasing colorectal cancer screening rates. So the vision for hospitals and health systems was to leverage their role as leaders in their communities to promote and advocate for colorectal cancer screening. And hospitals and health systems can do this in a variety of ways by focusing on increasing the quality delivery of colorectal cancer screening across the care continuum, focusing on quality standards, being seen as a leader with other stakeholders, particularly primary care, and working with underserved and uninsured in their communities, particularly in partnership with FQHCs. So what's the challenge to that vision? I'm sure many of you on the phone today could actually write this slide, but hospitals don't always see themselves as leaders of preventive care or leaders in the community. Now that's beginning to change, but that is still an issue for some. Also we hear about how the business model for hospitals to take on colorectal cancer screening, we hear that it's not clear. Hospitals are facing tremendous financial pressures. The landscape is constantly changing, so it can be hard to get a hospital or health system to focus on colorectal cancer screening. We also often hear that hospitals don't have strong linkages or feel that they can impact primary care. And then lastly, there's a fear that they can be overwhelmed by charity care. So that idea of sort of if you open Pandora's box, if you make yourselves available to the uninsured, you won't be able to keep up with the demand and you'll be overwhelmed by the need. Some of the other challenges to this vision are more logistic in nature. Sometimes we hear hospitals get stuck because they're not sure who their patient base is. We also hear about how hospitals can get stuck because they don't know how to measure their progress. This was something that came up very early on from the advisory committee. We also hear about hospitals struggling with how to manage patients. We like to say that colorectal cancer screening requires an activated patient. It's not a one-time, blood test. It is a process, and so managing that process can take some skill. Additionally, we hear that hospitals sometimes aren't sure how to work with the underinsured or the uninsured. It can require some new skills and can require some cultural change. So in order to address those many barriers, the Roundtable set out to develop this new handbook for hospitals and health systems in the area of colorectal cancer screening. And you already saw that slide. So what's actually in the new handbook? What we try to do is, by looking at real-life examples from the field, identify 12 critical steps that hospitals and health systems can take in this area. I'm going to spend the bulk of my time talking about those 12 critical steps. We also feature several case studies in which you see real-life examples of this work being put into action. And importantly, what we try to do is sort of peel back the onion. When hospitals launch interventions in this area, what does that look like in terms of the staffing requirement, the financial resources needed, the actual activities, the outcomes, and of course the lessons learned. We also provide advice on actually implementing the recommendations in this guide, and we point to many other resources. The hospitals and health systems that were featured in this guide were very generous in providing different samples and templates that you can look at and hopefully advance your efforts and save yourselves a little bit of time. Right here are the logos of the 12 hospitals and health systems featured in the handbook. And again, sincere thanks. They spent a lot of time with us on the phone in interviews and also reviewing the materials to make sure of their accuracy. And really the richness in the guide is due to their hard work and expertise. And so here's a screenshot of the 12 steps that are critical steps that hospitals and health systems can take. And I'm going to walk through these one by one. So the first 4 steps that hospitals can take have to do with how you get started. And the very first thing that hospitals need to do is to build the business case for colorectal cancer screening. Really, there's a number of benefits to hospitals and health systems for work in this area. They can find that it's much more effective than treating late-stage cancer, particularly when helping the uninsured or underinsured. It can help fulfill the community benefit requirement or fulfill Commission on Cancer standards. Their work in this area can help increase their visibility in the community, and it can help bring in new patients through their primary care networks. But really, I think the important thing is that when hospitals make this case, it's not just about convincing the medical leadership. You also have to appeal to the CFO and the others on the leadership team in order to get buy-in, because that buy-in at the leadership level is critical to empowering staff to actually implement these interventions and do it the way they need to. Second, a really important aspect for getting started is to pick your audience. Now, this can sound kind of basic, but the reach of hospitals is broad, and so picking the target audience can be anyone from focusing on just your primary care network, focusing on your entire patient base, focusing on your community. But really, I think the important thing is to figure out, what does a hospital want to do in terms of its mission, its resources, and its values, and get started. And one thing a lot of hospitals saw was that when they were just getting started in this area, it made a lot of sense to focus on their own employees first. One great thing is that hospitals are also one of the largest employers in their communities. And so if they just focus on their employee base, they can have a substantial impact and learn a lot and sort of pilot test some interventions along the way. Number 3 is that we saw it was very important to determine your baseline screening rates and commit to evaluating and tracking your efforts and your impact going forward. Again, hospitals sort of could get stuck on this very easily, and there's a lot of examples in the handbook about how hospitals determined who their target was going to be and how they were going to evaluate and track their progress. You know, I think if I were to say the most important thing is to just pick how you're going to evaluate. Disclose your limitations because there are no perfect measures, and get started, you know, rather than trying to find the perfect measure. Really just pick one and track it over time, and if you're not seeing the progress that you want to see, you know, course correct as needed. Number 4 is to partner with community organizations to customize the approach and reach underserved patients. You know, there are already a lot of folks in the sandbox in this area in your community. So whether that means partnering with folks like the ACS or with FQHCs, there are folks with a lot of knowledge about the cultural barriers that folks face. They have trust within the community. They can help advise about channels for how to reach the people that you want to reach. And so, you know, rather than going it alone, really figuring out who is already operating in the space and working together can save yourself some time and some work. Okay, the next 4 steps have to do with actual program design. And number 5 is using screening navigation. We heard again and again that hospitals who were doing this work successfully often relied on screening navigators to get folks through the process. As I mentioned earlier, this can be a complicated process, and so, you know, making sure that someone is there to hold their patient's hand to make sure that they have advice on how to return kits or how to do prep was really important. And in many instances, we found that from a relatively modest investment, this could actually pay for itself, because when good navigation is done, the hospitals often saw better show rates and better prepped patients so that they weren't losing money by seeing endoscopy slots go unused. Number 6 is offering patients multiple screening options. We know that colonoscopy is a great test, but we also know that many patients have hesitancy to go with a colonoscopy, either because they see it as a very invasive test or a very expensive test. Maybe they're very pressed for time and they don't have time to take a day off work for screening. So by offering patients a menu of options, that increases their odds of completing the screening process. We saw this both with our examples that are featured in the handbook, but also the research underscores that as well. We like to say at the NCCRT that the best test is the one that gets done. Number 7 is distributing fit kits, but doing so with a clear connection to primary care. The hospitals that were giving out fit kits that are featured in our guide like to say that people like free. But they don't just give out kits willy-nilly. They make sure that there is a connection, that they know how to get in touch with the patient, that the patient knows what to do, how to return the kit, where to go if that test comes back positive, so that they can complete the screening process. The reality is that if you just give out fit kits without really thinking through the connection to primary care, you're really just wasting resources. We do have some examples in the kit of folks who have done this with a flu fit program, which is one of the strongest examples out there, as Mike can attest, for doing this and doing this really well. Number 8 is seeking deeper engagement to facilitate a commitment to get screened. You know, going back to this idea that the interventions that were launched by these hospitals were often grounded in evidence-based interventions. So the hospitals and health systems went beyond, say, just putting up a poster in a waiting room to really doing in-depth either one-on-one or group education, often delivered in a culturally competent way. This really helped ensure that patients could have their questions answered and ensure that they were actually going to follow through on their screening commitment. And finally, the next 4 steps have to do with improving internal processes. Number 9 is employing multiple component interventions. In the CDC's community guide, they just showed that when more than one intervention is deployed, screening rates can increase by a median of 15 percentage points. And we certainly see this in the hospitals and their success stories. So rather than putting their eggs all in one basket with one intervention, the hospitals often employed many interventions, whether it was patient reminders, patient education, removing barriers to screening, navigation. They did many different components to ensure that the patient pathway to screening was smooth. Number 10, smoothing the path for patients in need of average risk colonoscopy. One great anecdote for the guide is that one of our systems featured in the guide was looking at the patient satisfaction with their endoscopy units, and they found very poor satisfaction. But this didn't have to do with distaste for the test or with colonoscopy or with the commitment that PrEP requires. It actually had to do with the colonoscopy wait times. So by really taking the time to see, does every patient actually need to consult with a GI first? And if they don't, just getting them on the pathway to screening, that could free up GI's time and free up colonoscopy slots so that the wait times weren't quite so long. Importantly, this was only done for patients who were at average risk when it was determined that they were medically appropriate. And Dr. Alberts is going to talk a lot about this in just a few minutes. Number 11 is examining workflow issues to maximize efficiency and impact. So as I mentioned, this can be a complicated process. So the hospitals featured in the guide often took the time to really determine roles and responsibilities in advance. They had a very clear process mapped out. Everybody understood their roles, and if something wasn't working, they knew where to zero in to adjust and course correct. And then finally, number 12, making effective use of EHRs for for population outreach. Some of the hospitals really use their EHRs to their advantage by not only identifying primary care patients and reaching out to them if they were in need of screening, but also alerting primary care providers so that they could deliver that powerful physician's recommendation as well. So beyond those 12 steps, there are other resources in the handbook that I think will help you. This is a great resource from the AHA, in which they really walked through how does a hospital's vision and their mission and their resources align with the role that they want to take. There are many different roles that hospitals can play, and there's no right or wrong role. It's really taking the time to determine where a hospital or health system is and what makes sense for them right now. Additionally, you'll find some work plans or action sheets in the guide. This is a resource from the CDC to help you get started and really figure out what you want to do and, the major tasks involved, the expected outcomes, potential challenges, and how to overcome that challenges. And how to overcome those challenges. This can just help you sort of organize your thoughts and get started. You'll also find many sample templates throughout the guide, such as this one, which is a sample workflow, a sample patient questionnaire, sample promotional materials, and sample EMR alerts. And lastly, so all that's great, but does it work? And I'm delighted to share that the hospitals featured in the guide really touted a number of different achievements that they were able to take back and share with their leadership. So they saw everything from increased screening rates not only among their employees but also their primary care patients. They were able to bring in new patients through their primary care networks thanks to increased screening outreach. They were able to increase their hospital's visibility thanks to a growing presence in the community. They were able to improve efficiency around colonoscopy scheduling and PrEP thanks to fewer no-shows and better PrEP. They were even able to reduce costs associated with treating uninsured patients in the prevention space. So we saw examples in which rather than paying for late-stage colorectal cancer in the ER, they were able to sort of have a cost-neutral effect by providing those low-cost, no-cost patients with colonoscopies, thereby getting ahead of this problem of late-stage cancer. And then finally, many were able to see their screening rates improved among the medically underserved in the community if they focused on that intervention. So with that, I know you really want to hear about some of the real-life examples that we saw, and so I'm going to turn it over to our good friend and amazing champion, Dr. Andrew Albert. Dr. Albert, I'll turn it over to you.
Thank you so much, Mary. Thank you, everyone, for allowing me to be part of this wonderful webinar. Mary, you touched upon a lot of what I'm going to cover so well, and so hopefully I'll just add to where the foundation that you started. I just want to say that Advocate is very proud to be part of the 80% by 2018 initiative, and frankly, I read the entire guide, and I wish I had a guide like this. It really, there's something for everyone in the guide, and I think it's tremendous. So kudos to you, Mary, and your team for getting all of us together. It's fantastic. So let's get started. My name is Dr. Andrew Albert. I'm the Medical Director of Digestive Health at Advocate Illinois Masonic Medical Center, and pleased to be here. Oops. So I think I just want to sort of go back to why we're here today. You know, there are a lot of champions. There are physician champions, hospital champions, but there are champions who are survivors. There's Stacy, Candace, Sarah, and then there's Michael, and people that you don't know, people who are championing messages. And I think that as we look for ways to build programs and do good for people, I think it's important to take into account what the champions are saying and realize that we're listening to them loud and clear, and we're going to continue to do so. So this is what the current colonoscopy screening process looks like, or at least that's how it feels. It basically consists of a primary care doctor faxing a report to the GI, and the GI faxes the requisition rather to the GI lab. The GI lab faxes the requisition to the central scheduling, or whatever version of this you want to say. And then what happens is the request is denied. It goes back to the GI. It goes back to the PCP, and it sort of becomes one big colossal you know, difficulty of papers going back and forth. And so this is the current process, and we felt that was an issue for us at Advocate Masonic. I would propose, and Mary touched upon this, that colon cancer screening is a stakeholder problem. That basically it's all stakeholders involved that need to own some aspect of colon cancer screening. And I just want to remind people that the payers have their own agendas in terms of, or rather, not agendas, but focuses rather of, you know, member health and cost of care. And the hospitals are focused on contracts and where they're going to do procedures. The endoscopy centers are focused on time. Gastroenterologists overbooked and clearly trying to figure out the procedures. The referring MDs, the PCPs, are dealing with compliance and barriers to care. Patients worry about days off, cost of care, and families could be somewhat unsupportive, or maybe somebody's mother or father needs them and they don't have the ability to take care of themselves. And so these are all the different issues and the different stakeholders involved in the process. So as a means of trying to figure out where the problems were, where the biggest hurdles were, we did sort of a road show. What we did was we went out to a PCP office associated with Advocate Healthcare, some distance away, back in July 2014, and we found that patients were dissatisfied with the process of calling and scheduling the first visit for the colonoscopy. The PCP was facing issues with compliance, whether the patients were having issues with distance or insurance issues. The PCP was frustrated by referring but never hearing back from the hospital, referring or not hearing back from the GI. And then there were some unforeseen impacts, like the procedure census was low at the hospital, or the hospital was losing revenue. There was leakage to a competitor hospital. This was impacting our ACO, as we have an ACO relationship, and then ultimately creating safety issues around patients who had, let's say, findings that were concerning and they weren't making it to the doctor. So a lot of people impacted by a simple process. So the secret sauce for us was the DASC program, or the Direct Access Screening Colonoscopy Program. And what we did was we piloted with one gastroenterology group and one Advocate PCP practice. And the way it works is the following. And I guess for all of you, this is like the base of the presentation. So this is the part you want to cue in. So the PCP, what they do is they fax an HMP and a form into the nurse navigator at the hospital. The nurse navigator reviews the HMP and finds that if people have health issues or risks or whatnot in the HMP, the patient's navigated to a gastroenterologist. But taking it back, assuming everything's okay, the nurse then directly schedules the patient for a colonoscopy. a physician walks in, not having met the patient before that day, does the procedure, after the procedure conveys the results, and then ultimately the pathology and the scope report is sent to the PCP and the gastroenterologist. Patients with advanced disease are then navigated not to the PCP, but to, assuming okay with PCP, to the oncologist or the surgeon, closing the gap in care, and the referral loop is closed. This is an example of what the requisition form is like on the left here. This is just a simple scheduling form that's faxed, and this on the right is a form that tracks for our nurse each step along the way where the patient was sort of left off, how many calls, who was contacted when, etc. These are patient materials that are standardized as a compilation of gastroenterologists and the nurse in terms of what the instructions are regarding the day, and also with regard to prep instructions. Those are all standardized before. And then ultimately, with regard to the DASC program, this is what it looks like. A gastroenterologist, let's say Dr. A on a Monday, let's assume he has a full day. He blocks out hours from 1:30 until 3. Dr. B blocks out 9 o'clock to, let's say, 10 o'clock. And so what the nurse navigator does is she just fills those slots with patients as they're approved. And we lately have been getting about 100 referrals per month into this program. The other thing that's unique about this program is that we have a nurse navigator, and this is something that was relatively new to us after 2014. The nurse navigator has a very high touch with a lot of different programs or people or sections in our hospital. Previously, as I'm sure a lot of you remember, the GI section was a section. It was sort of a siloed section of independent doctors, at least where we are, although some of you are health systems that are a lot more integrated. But for us, we didn't have a good connection, and so the nurse navigator could touch, the touch point could be the hospital administration, or it could be the oncology department, or the lab, or central scheduling, and basically could help us navigate those hurdles that exist. So the answer to our program, or the answer to our problem with all the stakeholders and the difficulties at each level, was the DASC program. We were able to accommodate healthy patients who needed a screening colonoscopy, or a FIT test, or Cologuard, or whatever other screening test was desired. We expedited and simplified the process. We reduced wait time from 6 months to 2 to 3 weeks, and I'll let you know that in Chicago we have some wait times longer than 6 months in various places, so this is significant. We increased access, and we skipped the traditional face-to-face consultation. That was a barrier. We provide a worry-free experience for patients, created a closed loop of communication, and facilitated quality growth and efficient scheduling. So you're asking, how successful is our program? Does this really work? The answer is yes. We have done it remarkably well. We're very proud of our accomplishments, but again, every hospital is different, and really any improvement is an improvement, and so we're very excited about this. We started in 2014 or so, 2015, and ultimately increased our 50 to 65 rate from 26% to 59%. I will tell you that in the past year, we've increased all 13 hospitals to over 70%. Most of them utilizing this program. So there's been a lot of buzz around just, tightening up the process. In terms of our numbers from 2015 to 2016, a little bit outdated. We started off with around 735 patients. This is to illustrate that around 323 patients were completed, and it's okay for some of the patients to fall off. Some patients aren't safe for the procedure and require cardiology clearance or something else, so that's okay. But as long as the process is in place, it's a win for everybody. 5 cancers were found in those patients, and we presume that of those 300 that were done, they wouldn't necessarily have made it through, or there would have been barriers to that number had they not been referred through the DASC program. One other quality measure, which was a plus for us in addition, was that our adenoma detection rate, which is now, as many of you may know, a quality measure of care in the digestive health umbrella, increased to 32.5%, the national average being 25%. Another unforeseen benefit was that patient satisfaction rates for us increased. There's a lot more hand-holding with the nurse navigator in the process, so the patient satisfaction rates were significantly better. Additionally, if you have a nurse navigator, then you're referring more to your oncology department, your radiology department, your surgery department, and I'll say that being located in an urban setting around some major academic centers, when cancer is found, it's a scary thing, and a lot of patients get really nervous, understandably. So our nurse navigator intervenes, and it's been very helpful to plug the patients in immediately to care by numerous services. Additionally, what was an added benefit, which some of you may or may not appreciate, is that in our ACO relationships, they have attributed lives of patients. We were able to determine the attributed lives of patients for colon cancer screening and plug them into this direct access screening colonoscopy program, allowing us to be ahead of the game in terms of managing these patients, which was a wonderful relationship between administration and our program, and just showing you how sometimes stakeholders have different, focus areas. This was an ability for all of us to sort of help each other, so that was a big win. We ultimately are now striving for greater than 70% this year, obviously for 80%, and thus far, leakage has decreased, and the safer practice of GI has been a tremendous win as well, plugging patients in into where they need to go in a fee-for-value culture. So the stakeholders win. Everybody wins in this model, at least for us. And I realize, again, that all of you have different models where you practice, so I respectfully suggest that there are variations here. And as Mary alluded to, there are various versions. I think there's one option for everyone in this guide. Having read the entire guide, I think that, even if DASC is not what's right for you, there's definitely something in there that will help. But in terms of stakeholders winning, we were able to decrease our barriers with patients. PCPs had timely access for screening. We were able to close the loop with a lot of patients with regard to care. The GIs were happy because the pre-procedure consults weren't necessary and block time was maximized. The GI lab was busier. Volumes were up and revenue was greater. And, of course, safety improved, and the ACO measures being met allowed us to be more ambitious. And ultimately, for a lot of you, I'm sure you'd appreciate that leakage was less of an issue. A quick case study, because you're thinking, okay, well, this data looks good, I guess. This is a case study of a 60-year-old Cantonese patient who has lost a follow-up numerous times over the 10 years that he was supposed to get a colonoscopy. His wellness visit demonstrated FOBT positive. He was referred to DASC. The nurse navigator was on this and had the interpreter paged and facilitating the appointment. His colonoscopy was done, and adenocarcinoma or colon cancer was found. The colon resection was done immediately, and the patient was cured. So that's our success story. So my conclusions. The DASC program works. What we did was we identified our barriers in the process, and we addressed them head on. And frankly, we came up with our own solution. It was very out of the box when we did this back in 2014. We identified all the stakeholders from administration down to the family members of the patients. We engaged all of them in our planning process. We demonstrated some success, and we built upon it. And my only suggestion, well, I have many suggestions, but my main suggestion is that whatever you do something. And this takes me back to college when I remember reading this statement that never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, is the only thing that ever has. I honestly believe that, and I think that if you're sitting there thinking, oh my God, how do I lift this process, just start. Just start somewhere, engage people, and it'll probably be a lot easier than you think. And with that, I say thank you and enjoy the rest of the webinar. Now I'm going to hand it over to Amanda.
So good afternoon. I'm really excited to be involved in this program. Very inspiring presenters. It's a hard act to follow, Dr. Albert, inspiring an advocate, and appreciate just being part of this program today. So Deaconess's approach to the shared goal of reaching 80% screening of colon cancer by 2018 started several years ago, and our key focuses were engagement, education, and early detection to bring that key. So I'll step through that and show you some of our results. So just a little background, I serve as the medical director for Deaconess Clinic, which is a part of Deaconess Health System in the southwestern part of Evansville, Indiana. So we're a not-for-profit organization. We have a local board. So Mary spoke to that community leader. We are very much in the position as a community leader here in Evansville. Just to give you some volumes, we have 50,000 discharges, 99,000 emergency visits, and 63% of the market share with at least 2,000 analytic cancer cases treated at Deaconess each year. So first step was engagement. When we decided we wanted to take that 80% by 2018 commitment, we knew we were going to need everybody on board. So from senior administration, our president and CEO of the health system, our vice president here at the clinic, myself, the medical director of our clinic department, our oncology committee chairs, surgeons, and nursing leadership took on the administrative piece, and then our clinical team was encompassed with the primary care physicians, our practice managers, health coaches who are part of our ACO system, nurses within our offices, community engagement specialists, and then our population health teams within our ACO.
I'm sorry to interrupt. Andrew, can you pass the baton to Amanda? It's looking like from my screen that it's not passed. So you just write it down to Amanda.
It shows up as it is, actually.
Okay, it might just be
apologies.
my screen.
Yeah, I have the baton. Can anybody else confirm?
Okay, it's just my screen then. Don't worry. I'm sorry I interrupted. Go ahead.
Oh, that's okay. Thanks, Mary. So our next step was education. So working in partnership with our senior administration and director of our cancer services, we came up with a 3-year action plan. And in year 1, again, just starting to increase the awareness and education among all those key groups. So our providers, clinicians, and patients, just making them aware of our Deaconess commitment to the 80% pledge. And then our population health teams working together to mine our electronic health record for the relevant data to establish our baseline to know exactly where we're starting among our clinic patients. And then laboratory was involved to look at what our current screening options were and our tools and kits. So then year 2, our focus was on our workflows within our primary care offices and what sort of quality indicators could we use to influence change. We then leveraged our electronic health record to identify screening processes and gaps in our practices. And we continued our education both internal and external, and I'll go into some of those details in the subsequent slides. Finally, in year 3, we're hosting colorectal cancer awareness seminars. We continue to use the Deaconess Clinic Quality Indicator across our health system to drive incentive comp for every single employee here at our organization. And then we continue our population health management initiatives to reach all of our patients within our ACO. So I think the proof is in the data, so I'll take you through it. And I like to be real straightforward about where we started. We were very ignorant. So in those first years, when we took on the pledge in April of 2015 through December, we were pretty ignorant about our data. It didn't look definitely clean. So we were working on that, as well as starting some kickoff meetings with all of our key stakeholders. We built the reports and validated those reports, and our GI physicians began to own the EMR updates. And what I mean by that is anytime one of our GI physicians would do a colon cancer screening, they owned the process of updating that health maintenance, a nice collaboration between our primary care and our GI physicians. We then began the Pledge Awareness campaign so that everybody in the community and organization knew that Deaconess was pledged to reach that 80% by 2018, and we began to rally the troops and the community. So then when we got our first set of data in December of 2015, it was a little shock and awe, but we knew that was our reality and we had lots of opportunity. So we looked first to our EMR to optimize it. So data capture was key. As you know, colon cancer screening can date back as far as 10 years ago. We had only been on our EMR since 2009, so we knew that there was a lot of data just living out there that needed to be brought forward so we could capture it properly. So we worked a lot on that, and then best practice alerts within our electronic health record and optimizing health maintenance to capture things and automate the process of recording care gap closure. We then invited our GI physicians to present at our annual primary care seminar, again to emphasize the importance and what the different modalities were so that every single one of our primary care physicians was up to date on the latest guidelines. We then had providers, staff, and patient education on colorectal cancer. So again, to Mary's point, reaching out to each stakeholder group with the appropriate level of education so we're kind of speaking their language and what their roles were in colon cancer screening to define them and bring them into the fold working towards that goal. We then developed a dashboard for provider performance compare, and we were very transparent with where Dr. Y and Dr. X compared on their colon cancer screening rates to sort of drive that performance. And then colorectal cancer screening was added to our physician quality compensation plan as a possible future metric so that they knew in the future that quality dollars were going to be at stake, and this was something that the organization felt was important and needed to be paid attention to. And as a result, we increased about 10 percentage points in that first year. So then our flywheel's going at this point. So the next phase, we knew we still had progress to make, so we developed a clinical practice guideline that was drafted in conjunction with our Deaconess Clinic Quality and our board, and certified by that group for our primary care physicians. We then rolled out a colorectal cancer screening initiative that had objectives, goals, and expectations for each individual, from clinical staff to clinicians to our front office staff. Each one were empowered with their goals and objectives and the resources that they need. They were armed with those tools to reach out to the patients. We then developed our pledge posters alongside a progress report, and you'll see a copy of that in the handbook. So in each one of our PCP lobbies was our pledge poster, and then kind of a temperature or a rate rather of where our screening was at. And each pledge poster was signed by all the clinicians and clinical staff in that primary care office. So as you're walking in, you're seeing, you know, the doctors and clinical staff I'm seeing today are committed, and here's where they're going on their progress. And then we began working care gap lists that we developed, both voluntary and mandatory. So no excuse for the physicians falling behind on their screening rates. We asked them to work them, and if still not meeting certain measures, it was a requirement. So by this point, we're on a path to succeed. Physicians were empowered and chose to put colorectal cancer screening on their quality comp plan for this final year. Then colorectal cancer screening at 80% incentive was aligned across our health system. So we're a unique organization where we have incentive comps tied from our senior administration all the way down for every employee. So reaching 80% was part of that incentive for every single employee. As a result, our benefits plan, we added HRA dollars for every employee that completed their screening. And then after returning from DC, where we met for the last National Colorectal Cancer Roundtable, we took back the idea from Geisinger that you'll find in your handbook of an outreach letter. And subsequent to that visit in DC, we came back and sent 5,900 open care gap letters directly to patients with open care gaps. So when we presented in DC, our percentage was 71%. We're now up to 76%. So although we didn't reach 80% by 2018, we're hoping that in 2018, we will get there. So some of our key takeaways, and to steal Dr. Albert's, this is the key slide you'll want to pay attention to. So activities that we took place were our community outreach and education. The pledge was so important to get us focused on what we wanted to achieve, and we engaged our leadership and physicians in that shared goal. The EMR reporting validation and optimization was critical as well. And then a system-wide clinical practice guideline that was endorsed by the physicians, again, creating that shared goal. Incentive alignment, so every employee was invested and rewarded for reaching this goal. The data transparency with physicians compare and aware drove our performance, and then working the care gap list as many organizations do. The resources that we devoted to this was included our community engagement specialists, and then we had clinical informatics to help us with our EMR optimization. We had both physician and administrative champions throughout the organization, and our population health teams also bought in. And the impact, in the end, we're excited to share that our Medicare screening rate was 80.32% by 2018. All payers combined are currently at 76%, and our motto is, we will get there. So with that, I want to leave plenty of time for question and answers, and I'll go ahead and give the baton to Dr. Potter.
Thank you.
Yeah.
Yes, that was just fantastic. If there's a question slide, there we go. That was fantastic, all three of you, Mary, Andrew, and Amanda. Thank you so much. Now we would like to take some time for questions, and we have about 12 minutes. And if you have a question, you can type it in the lower right-hand box, and I'll try to get through to as many as possible. And I think the question that shows up here on this could be a question for all of you about overcoming barriers around charity donations and linking with uninsured programs for uninsured, like the Links of Care projects. How do you get hospitals on board with these types of projects? I know you all work with hospitals, but how do we convince more hospitals to get engaged with this kind of work and get on board? Who would like to maybe, I don't know if any
Mike, I can try to.
Yeah.
Mike, I can try to take that. There are a couple hospitals featured in the guide, Feedy, Putney, as well as Surgery on Sunday, which is not a hospital but a nonprofit that worked for hospitals. And I think a few things that they did were, first getting leadership buy-in was really important, and sort of defining the actual commitment. So this idea that, you don't have to do everything. You don't have to solve the healthcare problem in our country, but, just give, one a week, one a month, just something to begin to help. And I think, keeping the ask doable, it makes it more likely that that you'll get a commitment. We've also heard that approaching the hospital sort of physician to physician helps. So, so it's one thing if, Mary Dorshan goes and asks you to help. It's another thing if one of your peers that you know well, asks the hospital to engage. As is mentioned in the guide, this can help fulfill things like the Commission on Cancer Standard or the community benefit requirement. And there actually is one study out there that Dr. Erica Sutton published that shows what I mentioned earlier, that if that when you compare the cost of, providing free colonoscopies to the cost of treating a late-stage colorectal cancer patient who shows up in the EHR, it's actually cost neutral. And so, this is the type of thing that a hospital can do without, busting their budget. And I guess one other solution that we saw Dr. Karen Kim do in Chicago is that they worked very closely with the hospital to use their GI slots that were going to go unused. So if someone broke an appointment relatively late, the hospital didn't think they could get someone in, the FQHC had a partnership with them to get folks in relatively quickly. So I don't think there's a perfect answer to that question. I think it is, to some extent, building relationships, but I do think we have some good examples to point to of, how it can be done in a way that works with the hospital's needs and values.
Great. And I just want to say that I think that's a great set of answers. I am seeing some of the questions, but I'm unable to scroll through all of them, so I'll continue to do my best. But there were a couple questions. Someone wanted to know what H&P stands for. I think it stands for History and Physical. So that should clear up a couple questions. There was some questions about what the training of the community engagement specialist needs to be. Is it a nurse or is it a lay person? How do you find these people? How do you train them? Maybe Amanda or
I'm happy to tackle that one. Can you just, the first part of the question, how do you train which person, sorry?
Yeah, how do you identify and train someone to work with the community? Should it be a nurse? Should it be a lay professional? How do you figure out who the right people are to do this type of work?
So I think it depends on the framework. In our situation, the person who helps with this is a care coordinator. There is a nurse on hand to help, but in terms of ordering the prep, that typically comes from a doctor or a nurse. But in terms of somebody who can handle the logistics of scheduling patients and going through the information with them, it's somebody who's had some medical experience, but it does not have to be a nurse or a practitioner or a medical assistant. It could be somebody who's been administratively working within the medical arena. I think it's really site-specific, to be honest with you.
Okay. Anything else to add? Others about staff training? No. There's a question for Dr. Bolliver about how much in HRA dollars were given. How did you determine the amount, and what proportion of eligible employees were screened with your program?
Oh, yeah, that's a great question. So I actually don't have that in front of me, but my memory recalls it was, I believe, $50 towards HRA. And we have an HRA program where we reward for several preventative things, and it's from the list. So if you're getting your mammogram done, your colon cancer screening done, your physical done, those types of things, those all have to carry the same sort of monetary. And I'd have to go back and look at the data on, we have not followed that specifically as how many colonoscopies or colon cancer screenings resulted from that specific initiative. We were in the mode of, we want to get to 80%, what makes sense, we're throwing everything plus the kitchen sink at this. So I'd have to go back and look at that data. But our screening rates are for all patients that come to those primary care physicians at Deaconess Clinic. So that's a great question. I'll have to go back and look at our data.
Okay. And there's a question about, it seems like these projects are focusing on hospitals delivering colonoscopy, which is understandable since that's a big part of the service that they do for the community. What about using fecal immunochemical testing, and how can hospitals get involved with that more? There's a question about whether those are things that you engage with or whether those are things that you're considering and how you would approach it.
I'll take that first. We actually do offer fit testing for patients. To be honest with you, as it gets to the end of the year, a lot of hospitals and health systems have this backlog of colonoscopy spots in terms of not being able to get people in time. So we do offer fit testing. I think the best way to do that or do this is either through our program, the nurse navigator or the coordinator offering fit as an option, or to be honest with you, more direct impact would be having it done in the PCP's office. These days, the EMRs are now flagging patients who are have attributed lives to the ACO, or patients who just haven't had their colorectal cancer screening. That's the point in time where you have the greatest impact for a nurse or a medical assistant to say, hey, here's a fit test. Why don't you go ahead and do this? I think that's much more effective in that setting. So although our model does offer fit testing, I think the biggest impact you could have is from the primary care office in terms of somebody flagging that a colon cancer screening had not been done and then offering that at the site.
Yeah, Dr. Mary, I would also say, I'm sorry, go ahead.
No, I was just going to add to Dr. Albert's comment that at Deaconess we have the same approach. It's as soon as those patients show up at our offices and the primary care offices, we're looking for those flags. We have a custom handout that we crafted with the American Cancer Society that walks the patient through patient-friendly materials about their options so that they're already sort of prompted to that. And then the clinical staff pick it up from there saying, you know, I know you're due for that. You've reviewed this. Let me help you answer some questions and talk you through your options. And then the primary care physician comes in and follows up with that and, you know, has a very focused shared decision-making with the patient, you know, to go through that and drive whatever. Our approach has been the option is not to do nothing. We're going to do something, and let's figure out what's best for you.
Right. I just want to add that there are hospitals that have done things such as, you know, it's great to have the opportunistic approach in the office where people are given a choice, but there's also the option of mailing kits to patients. Some hospitals have done that. Some hospitals have done programs like, well, with a program that I have experience with, the Flu Fit program, where they may have an annual campaign where they're bringing in a lot of patients for flu shots. You can have a staff member provide fit kits during that period of time. So there's lots of ways potentially to do that. And the other thing is that since one of you mentioned the American Cancer Society, probably the last question here that we have time for would be to talk about how the American Cancer Society has been supporting these efforts and how we can engage with them more to help the hospitals can engage with that resource to improve their screening rates. I think Mary probably is that one that would be good for you.
Yeah, that's a great question. And you know, many of these folks came to our attention through the work of the ACS hospital system staff, which are just an amazing group. They're especially trained in working with hospital systems and are experts in quality improvement. So, you know, if a hospital is interested, we can certainly help connect you with your ACS local hospital system staff, and they're just, you know, I think can be a tremendous resource who knows the issue but also knows the community very well.
Yeah, I think armed with this this manual and then calling the ACS and asking for some consultation about how to put it into practice for your local hospitals, I think you'll be in really good shape. I do want to thank everyone. A huge thank you to our speakers for generously sharing their slides, their slides, and their presentations, their expertise with us, as well as a thank you to the CDC for providing funding that made developing this new resource possible. And finally, thank you to the advisory group that helped us develop the content for the guide, and especially to all the expertise from the many health systems featured in the handbook. And we so appreciate your willingness to share your know-how and expertise. Please do go to the NCCRT.org website and connect with us on social media to find out about upcoming roundtable webinars and other news. And for more information on today's webinar, please email nccrt@cancer.org. We will keep a record of all the questions that were answered, that were posted, and try to figure out ways to get answers to you. But if you do need more information, please do email us. Thank you very much, and good afternoon.